You ever had a baby in the neonatal unit that no matter how hard you try, you just can't insert a UAC? You have two options. You could either perform repeated frequent capillary blood gas monitoring and non-invasive blood pressure monitoring, but this is not ideal in a critically unwell neonate. You could also insert a peripheral arc line, which will allow more adequate monitoring of their physiology. This is a tricky procedure and has risks of complication, so only ever do it under senior supervision. I'm Dr. Matthew Sayers, a consultant paediatrician with over 10 years experience in paediatrics, and I have inserted a number of peripheral arterial lines with varying degrees of success. In this video, I will share my tips and experience from successful and unsuccessful peripheral arterial lines. In this video, we will focus only on radial peripheral arterial lines in neonates, as this is what I have experience in. Links to all guidelines and documents are available in the video description and also on the OLAS medical app. An arterial line is generally required in babies that are critically unwell and require continuous monitoring of their arterial blood pressure. For example, a baby with severe persistent pulmonary hypertension of the newborn. It is also required for babies that have persistent hypotension requiring inotropes. It's required for babies that will require frequent sampling for their oxygenation and ventilation. For example, a baby on high-frequency oscillating ventilation. Finally, it is indicated for babies that require an exchange transfusion, as the arterial line is vital in removing blood from the baby. As mentioned, umbilical arterial lines are often easier to put in than peripheral arc lines. However, if these are unsuccessful or contraindicated, a peripheral arc line should be attempted. For babies that require single or infrequent blood gas sampling, capillary sampling should be used. I have linked my video on capillary blood gas sampling at the top of this video. Arterial lines are contraindicated if there is poor collateral circulation in that artery, if there are signs of poor circulation, there has been a recent attempt in that artery, or if there are severe limb abnormalities. Always perform Allen's test before performing a peripheral arterial line. Uncontrolled coagulopathy is also a contraindication. Strict ANTT is required when inserting and also when accessing an arterial line. This video by Neosim shows you the correct technique for accessing an arterial line. In a baby, the modified Allen's test is performed by lifting the baby's hand upwards, occluding both the radial and ulnar artery, and applying blanching pressure to the hand. Release the ulnar artery and observe the hand to see if the blanched area returns to its normal colour within 10 seconds. If it does not, do not perform radial artery cannulation in that arm.
Firstly, prepare your equipment. You will need at least a size yellow cannula, 24 gauge, ChloraPrep applicator, a dressing and steri-strip set to secure, a flushed extension set, a 3-way tap with an arterial line connector, and a saline flush. Attach your arterial connector port to your 3-way tap and flush all lumens. Position the patient's arm with the wrist extended. Gently palpate the radial pulse. In premature babies, it may be useful to place a transilluminating vein finder device under the wrist to assist with visualization of the artery. Clean the area and allow to dry. Slowly advance the tip of the cannula through the skin. Advance at a 45-degree angle slowly until flashback is obtained. Slowly advance the plastic cannula tubing over the needle. It should advance easily and the needle can be removed. Pulsatile bleeding from the cannula will occur if successful. Quickly attach the extension set and slowly flush with saline. It should flush easily, but if done too quickly, it can cause blanching of the hand, which should be avoided. Secure the cannula with steri-strips and a dressing and flush again. Attach the flushed 3-way tap to the extension set and attach this to a transducer. Make sure you prescribe a heparinized saline infusion to avoid blood clots developing in the arterial line. Always make sure the arterial line is appropriately labelled to avoid accidental injection of fluid or medication.
This procedure has a number of complications and should only be performed after senior discussion. The main complications are thrombosis, thromboembolism and vasospasm, which can lead to necrosis, gangrene and autoamputation of the extremities. A large hematoma, infection, Local aneurysm, tendon or nerve damage can occur. If you have any doubt about an arterial line, take it out if the line isn't bleeding back well or the blood pressure tracing isn't working. First check distal perfusion is okay. Reposition the hand and check that there are no visible clots within the transducer. Flush the line and consider removing the dressing to ensure it's not kinked. If the line remains persistently problematic, it is better to remove it before more severe complications occur. What should you do if the baby suddenly develops severely reduced perfusion distally to the arterial line? Firstly, remove the arterial line immediately and contact a senior neonatologist. Raise the affected limb and put a warm compress on the contralateral limb to promote reflex vasodilation. Perform an urgent Doppler ultrasound to identify the cause. If this persists, consider anticoagulating and using low molecular weight heparin. Discuss with a haematologist and vascular surgeon before doing this.
Thanks so much for watching. Please like this video, comment with any clinical questions or feedback you have, and subscribe to the channel and our other social media accounts including Instagram, Twitter, Medall and OLAS to stay up to date with future videos. I look forward to seeing you again soon.